Management of atrial fibrillation in the setting of heart failure has undergone a major paradigm shift. The historical approach of rate control as a purely palliative measure has been largely superseded by aggressive early rhythm control. Catheter ablation is no longer viewed as just a tool for symptom management in refractory patients. It is now recognized as a potent disease-modifying therapy that improves left ventricular ejection fraction, reduces hospitalizations, and lowers all-cause mortality. Here is a breakdown of the current clinical consensus and the landmark trial data driving these changes. The 2023 guidelines firmly prioritize sinus rhythm maintenance in heart failure. Catheter ablation is highly endorsed over antiarrhythmic drugs due to its superior efficacy and better side effect profile. Catheter ablation is recommended for patients with AF and heart failure to improve symptoms, enhance left ventricular ejection fraction, and reduce the rates of hospitalization and mortality, with class 1 and 2A recommendations in various subsets. Pulmonary vein isolation remains the cornerstone primary lesion set for these procedures unless a discrete arrhythmogenic focus is identified. The recommendation upgrades are anchored by robust data demonstrating survival benefits across the spectrum of heart failure. The CASTLE AF trial in heart failure with reduced ejection fraction. This trial was the initial turning point for patients with heart failure and reduced ejection fraction. It demonstrated that catheter ablation was vastly superior to guideline-directed medical therapy in reducing both all-cause mortality and hospitalizations for worsening heart failure. CASTLE HTX in end-stage heart failure. Published in 2023, CASTLE HTX answered whether ablation is a viable option for the sickest patients, those with end-stage heart failure with reduced ejection fraction, LVEF 35% or less, being evaluated for a left ventricular assist device or urgent heart transplantation. The CASTLE HTX trial was terminated early due to the overwhelming efficacy in the ablation arm. The composite endpoint of all-cause mortality, LVAD implantation, or urgent heart transplantation occurred in just 8% of the ablation group versus 30% in the medical therapy group. At 12 months, the ablation arm saw a plus 7.8 increase in percentage of LV ejection fraction compared to 1.4% increase with GDMT. CABANA trial. While previous trials focused heavily on heart failure with reduced ejection fraction, the CABANA trial's heart failure subgroup, where 79% of the heart failure patients had an LVE of 50% or more, that is heart failure with preserved ejection fraction group, extended the evidence of ablation to the heart failure with preserved ejection fraction group. Patients randomized to ablation had a significantly lower rate of the primary composite endpoint, which included death, disabling stroke, serious bleeding, or cardiac arrest, compared to drug therapy, 9% versus 12.3%. All-cause mortality was notably reduced, 6.1% versus 9.3%. The absolute benefit of catheter ablation is actually more pronounced in higher risk patients like those in CASTLE HTX, though the window for intervention requires careful patient selection before irreversible left atrial myopathy sets in. Pathophysiological rationale. The outsized benefit of achieving sinus rhythm in heart failure patients compared to the general population likely stems from reversing the vicious cycle of AF and heart failure. Restoring sinus rhythm eliminates tachycardia-induced cardiomyopathy, restores active atrial contribution to ventricular filling, the atrial kick, which is crucial in heart failure with preserved ejection fraction, and reduces the neurohormonal activation that drives progressive ventricular remodeling.